Hey there, Dr. Cameron Marshall here from Complete Concussions. This is a presentation that I gave to the Sports Chiropractic Conference in Toronto on November 8th, 2025, and I thought I would share it with you today because this is a practical approach to return to sport. Now, this is a topic that has a lot of controversies around it, so I wanted to provide you with an updated framework as to how to properly return someone to sport after a concussion injury. So here's the outline for the seminar. So we're going to talk about the updated diagnostic criteria. We're going to talk a little bit about pathophysiology and biomechanics because that is key to understanding proper return to sport. And then we're going to talk about a controversial topic, to baseline or not to baseline. Then we're going to cover the new Amsterdam guidelines in terms of return to play. And we're going to talk about physical exertion testing as part of your return to play process. So let's get into the diagnostic criteria. Concussion versus mild traumatic brain injury, or MTBI. These terms are interchangeable for the most part. However, in 2023, the American Congress of Rehabilitative Medicine updated their mild traumatic brain injury diagnostic criteria. They came up with two types of mild traumatic brain injury. You could have mild traumatic brain injury with neuroimaging evidence of structural intracranial injury. These used to be called complex or complicated MTBI. Now it's MTBI with neuroimaging evidence of structural intracranial injury. The other type is MTBI without neuroimaging evidence of structural intracranial injury. This used to be called uncomplicated mild traumatic brain injury. Now what they say here is, according to this new diagnostic, this terminology, the diagnostic label concussion can be used interchangeably with mild traumatic brain injury when neuroimaging is normal or not indicated. So if there's any neuroimaging evidence of structural injury, you have to call it mild traumatic brain injury with evidence of neurostructural injury. However, if there isn't, you can call it a concussion injury. All right? So the diagnostic criteria or decision tree goes as following. So if there is a mechanism of injury or a plausible mechanism of injury, meaning some sort of acceleration, deceleration to the head, and there is a clinical sign, one or more clinical signs. Now a sign is something you can visibly see. So the person gets hit, they're off balance. Person gets hit, they're unconscious. Those are signs. If they are not better accounted for by something else, like for example, you see the person get hit, they're off balance, but they're also intoxicated at the time, well, that could be accounted for by something else. So that wouldn't necessarily qualify. But if this is not better accounted for by something else, then it's a mild traumatic brain injury. Here's the signs, right? These are the typical signs that you can see. And then going down the diagnostic decision tree, if you don't have any signs, well, now you're into the next kind of, criteria here. So you have a mechanism of injury, you don't have any signs, but now you have to have two or more symptoms plus clinical or laboratory findings. And then again, if it's not better accounted for by something else, then you're dealing with a mild traumatic brain injury. Now let's talk about clinical or laboratory findings. Here's what they say. Cognitive impairment on acute clinical presentation, balance impairment on acute clinical presentation, ocular and motor impairment or symptom provocation in response to vestibular oculomotor challenges on acute clinical exam, or elevated blood biomarkers indicative of intracranial injury. Now, here's what they also say. Note, impairment is defined as clinically meaningful discrepancy between post-injury test performance and age-appropriate normative reference data, or where available pre-injury test performance. Now here's the kicker. We don't have good quality age-appropriate normative reference data. So the best way to do this is actually to compare to pre-injury test performance. And we're going to get into baseline testing as a topic coming up, but I'll just have you know that this doesn't really exist. We don't really have we don't have a good data set of age-appropriate normative reference data, and I'll show you why. So let's talk about biomechanics and pathophysiology of concussion. Concussion is a brain injury due to acceleration, deceleration of the brain, right? We used to think it was the brain bashing up against the skull, but now we know it's actually a deeper white matter injury that comes from the stretching of brain cells. So you can see here in this GIF that's happening, when that brain gets hit, it goes through this fluid wave. Now, if you picture every single little kind of fiber in there getting stretched as it kind of stretches up and goes through that fluid wave. So what you get is this stretching and shearing of brain cells. And what I mean by shearing is that you have white matter down here and you have gray matter right here, and those two tissues are actually different densities, so they accelerate and decelerate at different rates. So you're going to get cross shearing between those two layers, and you're going to get stretching of those brain cells as those axons get stretched. So there's two phases to a concussion injury. The first is the excitatory phase. This is in the initial few minutes, seconds to minutes. And then you have spreading depression, which is the second phase. So let's talk about this stretch. So if we think about an axon as being this kind of long tube, right? A brain cell is this long kind of tubular structure. Inside that tube, we have a high amount of potassium. Outside of that tube, we have a high amount of calcium and a high amount of sodium. Now, what these molecules want to do is they want to go down their concentration gradients, meaning that if potassium has a high concentration inside the cell and a low concentration outside the cell, it's going to want to leave the cell. It wants to disperse evenly. Same thing with calcium and sodium. There's not a lot of calcium, not a lot of sodium inside. There's a lot on the outside, so they're going to want to get into the cell to try and disperse more evenly. That's called a concentration gradient. Now, these axons actually aren't hard, solid tubes. They're porous. There's little holes in them. So when the brain undergoes acceleration, those little holes get spread open even further. They get bigger for a split second, right? Open, closed, right? Brain gets stretched and it's back to normal. Well, in that split second that we get stretched, what's going to happen? The potassium is going to leave and the sodium and calcium is going to come rushing in. This is what happens during a normal action potential. When the brain cell receives a signal in the normal state, it goes through ion exchange and then action potential, right? Sodium in, potassium out. Boom, boom. Now, if this happens as the result of a stretching injury, now this action potential situation is happening in millions of brain cells all at the same time, even though they didn't receive a signal. So now you picture it, things aren't coming in a nice congruent message. It's millions going all over the place. So the person may lose consciousness, they may see stars, they may have difficulty with balance because they're not getting proper information from the environment. Their brain is undergoing an electrical storm, which is chaotic. They can't think straight, they can't speak straight. So that is the initial few seconds to minutes of a concussion when that electrical storm is going on. Now, how much force does it take to cause this degree of stretching to actually result in concussion injury? Well, across the board, most of the research shows that you need about 100 Gs of linear acceleration. The range is anywhere from 70 up to 120-ish, depending on the study you read, but generally the mean peak linear force is about 100 Gs. For rotational acceleration, you can see here anywhere from kind of 3,500 rads per second up to 7,000 rads per second squared. When we look at comparative g-forces, looking just at linear acceleration, you can see that standing on sea level is 1 g, right? A sneeze is 2.9 g's. Space shuttle launch and re-entry gets you about 3 g's. High g roller coasters go anywhere from 3.5 to 6.3, and so on and so on and so on. Now, what you can see here is heading a soccer ball is about 18 to 23 g's. Mean peak linear force in hockey in boys aged 13 to 16 is about 18.4 Gs. That's the average. Mean peak linear force in tackle football at high school and college ages is 25 Gs. An Olympic boxer punching someone in the face with a jab works out to about 58 Gs. A car accident where your airbags deploy, so your airbags are set to deploy at a change of velocity of 50 kilometers an hour, that translates into 60 Gs at the seatbelt. Concussion in children, the mean peak linear force is 62 Gs with a range of between 30 and 90. And in high school, it's 100 Gs with a range between 70 to 120. So you can see that it takes a lot of force to cause a concussion injury, right? Your sneezes are not causing concussions. Even your typical hockey hit, your typical football hit, not causing concussions. And if you look at data from the NFL, for example, less than 0.02% of impacts actually result in concussion level forces. So it's not every hit that's causing concussions. It's the really big hits. And typically when the person is unaware that they're going to be hit, that's why there's more G-force translation. So what happens when you go through this kind of what's called the neurometabolic cascade? So we get depolarization and action potentials, like I said. You're going to get release then of excitatory neurotransmitters. The one here is glutamate. So glutamate goes and it binds to these receptors. You're also at the same time going to get potassium coming out of the cell, sodium and calcium coming into the cell. And as this glutamate comes out and binds to the next neuron, you also open up these NMDA receptors, which act as calcium channels. So now you get even more calcium flooding into the cell. Calcium has an affinity for mitochondria. Calcium really likes to get into the mitochondria for some reason. The mitochondria is how we produce ATP. Now, if you remember, how do we reset the ion balance after an action potential? Well, we need the sodium-potassium pump. It pumps potassium back in and it pumps sodium out, but because it's going against its concentration gradient, we require ATP. ATP is our energy store. That comes from the mitochondria. But we have a problem. The calcium has gotten into the mitochondria and impaired our ability to produce ATP with oxidative metabolism, which is our most efficient way of producing it. So we have increased ATP use after concussion because we need to reset the balance in millions of brain cells that have all been firing. But unfortunately, we have decreased production because our oxidative phosphorylation has gone kaput because of the calcium that's messing it up. So then we have the second phase of concussion, which is called spreading depression. And what we see here is a gradual drop in ATP stores after injury. This is in a mouse, all right? So the humans go through the same process, but it's more expanded. This is in a mouse. We have a sham group here, so no concussion. So think of this as your control. This is the normal level of ATP. 1 minute after injury, we can see we're already starting to drop. 10 minutes after injury, 30 minutes after injury, 2 hours after injury, we've hit significant difference. Okay, this single star means we're now significantly different from the sham group. 6 hours later, the mouse hits its peak low. 15 hours later, still significantly different. 24 hours later, still significantly different. 48 hours, still significantly different. And it's not until 120 hours, which is 5 days, that we have no more significant difference. So a concussion in a mouse takes 5 days to go through this metabolic recovery process. Here's the problem. During this period where the ATP levels are low, the brain is vulnerable, whereby if you get another concussion, you're already low in your ATP, you get another one, now you drop even lower. Okay? So here's what we do know. Mild traumatic brain injury versus severe traumatic brain injury. A mild traumatic brain injury, or concussion, is a 20% reduction in ATP. It represents a reversible energy deficit, right? We're not damaging the brain cells. They have some, reactive oxygen species buildup. They have some issues with phosphorylation, but it's reversible. So after we kick the calcium out, things come back online and we're able to start restoring those energy levels. Severe traumatic brain injury, we end up with a 50% reduction in ATP, and some of those brain cells die. They actually have permanent disability or permanent dysfunction in the phosphorylating capacity of the mitochondria, and to the point where they can't sustain the own life of their cell, and so they die off. If they die off in mass, you're going to get lots of swelling happening inside the brain. If you have two concussions that happen in close temporal proximity, that can lead to the same irreversible damage that we see in severe brain injury. And here's a study that shows just that. Another mouse study. Remember, we said it takes about 5 days for the mice to get back up to their normal levels of ATP. So this group right here is a control group. No concussion delivered. This group right here is a mild traumatic brain injury. They got 1 concussion. This group here is a severe traumatic brain injury. Okay? Mild traumatic brain injury, you see there's about a 20% reduction in their ATP. Severe traumatic brain injury, you can see there's about a 50% reduction in their ATP, right? This one is about half of this one, 50% reduction. What these researchers wanted to do is they wanted to say, okay, if we were to give these animals a second concussion, what would happen? Well, if they waited the full 5 days, they gave them another concussion. And you can see these 2 stars here mean that these 2 groups were not significantly different from one another. Meaning if you get a concussion and you fully recover from a metabolic perspective, it's just another concussion. No additive or cumulative effect. However, if they gave the animals a second concussion on day 3, they were not significantly different than a severe traumatic brain injury. And in fact, 10% of the animals in each one of these groups died as a result of that secondary injury. So the big thing with concussion is recovery. This also makes a difference in terms of CTE, right? Perhaps the CTE issue isn't because of concussions, but is due to improper management of concussions. Take this other mouse study. Every single one of these groups got 5 concussions, with the exception of the sham group, which got none. The sham group went through the anesthetizing process and all that stuff, but they never actually got the concussion. So group 1 got 5 concussions. Group 2 got 5 concussions. Group 3 got 5 concussions. The only difference was how far they were spaced out. So group 1 got 5 concussions. They got a concussion every day for 5 days. Group 2 got a concussion every week for 5 weeks. Group 3 got a concussion every month for 5 months. 1 month after the final injury was given, group 1 had a significant difference from the sham. And they tested them things on like water mazes and kind of cognitive function to see how they were doing. They were significantly different than the sham group. The group that had a concussion every week for 5 weeks, significantly different than the sham group. The group that had a concussion every month for 5 months was no different than the sham group. So all of them had 5 concussions. The only difference was that this one was able to fully recover. This one was kind of borderline, right? This one was definitely nowhere close to recovery. 1 year after the final concussion, this group was still significantly different. This group here had a non-significant difference, meaning that it was getting closer. This group here still had no difference. So is it the number of concussions you get, or is it the amount of recovery that you get between each concussion? Now this leads us to humans. Humans go through the same process like I mentioned. This is a control group. If we look at these black bars, this is 3 days after concussion, 15 days after concussion, 22 days after concussion. You notice how we're still significantly different 3 weeks after the injury. It's not until week 4 that this single star disappears. Day 30, this single star disappears, which means what took 5 days in a mouse takes anywhere between 22 to 30 days in a human. So you're looking at 3 to 4 weeks for recovery. Every single person in this study was asymptomatic before they hit the day 15 timeline. So that means that symptoms do not equal recovery in concussion. Take it a step further. There was 6 people in this study that didn't want to wait the full 30 days. They decided, I'm going to go back and play my sport. Screw your study. So we have here, after the first concussion, so here's the people, right? So we have boxing, rugby, soccer, kickboxing, and boxing. Symptoms after the first concussion, right? Headache, amnesia, 2 to 3 symptoms per person, 2 to 3 major symptoms per person. Symptom duration after the first concussion, 3 days, 4 days, 8 days, 7 days, 8 days, 5 days. Typical symptomatic concussion recovery. The time between injuries, meaning they got their second concussion, 10 days after the first one, 9 days after the first one, 18 days after the first one, 16 days, 21 days, or 19 days. Look at the symptoms after the second concussion. Way more symptoms. Now look at the symptom duration. 52 days, 59 days, 44, 35, 24, and 33. And you can see that it's directly in proportion to how much time passed between their injuries. Those that had the longest amount of time between those 2 injuries had the least amount of recovery time after the second one. Those that had the shortest amount of time had the longest. So if you look at this one, the shortest one, 9 days, symptom duration, 59 days. That's the longest symptom duration. This person had the longest time between concussions at 21 days. Their symptom duration after the second was only 24 days, the shortest. So it's directly proportional to how much recovery time you get between injuries. Now look at how long it took their NAA or their ATP levels to get back up to normal levels. After 1 concussion, it takes 30 days. After the second concussion, if it happens in that window, it takes now 120 days. So you go from 3 to 4 weeks to now 3 to 4 months. And now if you're still vulnerable in that period, imagine this. Player, 52 days after their second concussion, 52 days after their second concussion, they're now asymptomatic. You don't think they're dying to get back to their sport? Probably. And if that doctor's just basing their recovery on symptoms, they're going to say, yeah, you're good to go. They still have another 68 days until they're actually recovered. So in that 68-day window, what happens if they get hit again? That's the big issue with concussion, is this recovery time. Because once you get behind, because you've had 2 back-to-back, because we didn't handle the first one properly, because they went back too early, they got our second one, now the recovery time is expanded, and then they're going to go back based on their symptoms at 52 days, and they get hit again in that vulnerable window because it's still not recovered yet. Now they're in trouble. How long does it take now? Well, we don't even know. Are we starting to create permanent damage? Potentially. So it's all about concussion recovery, not from a symptom perspective, but from a metabolic perspective. Well, how do we judge concussion recovery? This is from Berlin. This is years ago, 2017. Recent literature suggests that the physiologic time of recovery may outlast the time for clinical recovery. The consequence of this is that athletes may be exposed to additional risk by returning to play while there's ongoing brain dysfunction. Yeah. Okay, if we look at this, neurocognitive performance of concussed athletes when symptom-free. At the asymptomatic time point, almost 40% of concussed athletes continue to demonstrate neurocognitive impairment. The conclusion: the exclusive use of symptom reports in making return-to-play decisions is not advised. A multifaceted approach to concussion assessment that includes evaluation of a myriad of functions is warranted. Look at this one here. Typical recovery, they say, is 7 to 10 days. This study challenged that. So they were given neurocognitive vestibular ocular motor outcomes, and they looked at symptoms. So they found that recovery time across all the outcomes when they brought in neurocognitive and vestibular ocular motor factors was between 28 and 28 days. That's the vulnerable, that's what we're trying to get to. And that's what they found when those functional elements went back to normal. Symptoms demonstrated the greatest improvement in the first 2 weeks, although neurocognitive impairment lingered across various domains up to 28 days. Vestibular ocular motor decrements also resolved between 1 and 3 weeks. When the recommended comprehensive approach is used for concussion assessment, recovery time for sports-related concussion is approximately 3 to 4 weeks, which fits with the metabolic side of things. How perfect is that? Which is longer than the commonly reported 7 to 14 days, which is based on symptoms. So again, recovery. How does the recent Amsterdam consensus define concussion recovery? Well, it's important to consider functional outcomes that are meaningful to athletes and patients, such as a return to their pre-injury levels of function and performance. So how do we know what their pre-injury levels of function and performance are? Well, that brings us to baseline testing. Now, what is baseline testing? Well, it's a procedure. It's not a test. Some people will do just one test and think that that's a baseline. But we know that a single test is not good. If you're just going to do a SCAT test, the SCAT test normalizes within 3 to 4 days after the injury. That's not going to help you make a return to play decision at 3 to 4 weeks after the injury, if it's already back to normal 3 to 4 days after the injury. Okay, so SCAT is useless as a return to play measure. It can help you on the sidelines because that's immediate, but it can't help you in the future when making a return to play decision, which is exactly why baseline testing is needed in the first place. Neurocognitive testing by itself isn't good. You have to include a variety of different measures. So unfortunately, this idea that if you do one of these tests, that's considered a baseline, that's created confusion. And also there's confusion around the idea that people think that the reason you're doing a baseline is to make your initial diagnosis. That's not why you're doing it. You're doing it to help with your return to sport decisions, because you need tests that are good enough and sensitive enough to pick up dysfunction after symptoms go away. All right? Purpose of baseline testing is not diagnosis. However, the new diagnostic criteria is calling that into question, because now it suggests that you need 2 or more symptoms plus objective evidence of impairment, which is compared to their pre-injury baseline, if you have it. So why wouldn't we be trying to get it? We should be trying to get it. If we're working with athletes, we should be making sure all of them got it. And also, even the SCAT says that it can be helpful. Preseason baseline testing with the SCAT-6 can be helpful for interpreting post-injury test scores, but is not required for that purpose. Okay, it's not required for it, but without it, what are you going to do? How do we know that they wouldn't score that normally? Computer-based test batteries, especially in comparison of reaction times against patient baselines and community norms, may be useful. Yeah, they can be useful. Of course they can be useful. But the big thing is for making safer return to sport decisions. So a good baseline should involve a battery of tests that test various areas of brain function, both cognitive and physical. You have to have good test-retest reliability, meaning that they should be fairly stable for 6 months up to a year, and they have to be sensitive enough to show subtle dysfunctions beyond symptom resolution. Remember, that's why you're doing it. So let's look at who's for and who's against baseline. Right here, we're going to show you groups that are somewhat, not necessarily in support of, but they do either recommend it or suggest that it can be helpful for this process. International Consensus Statement, SCAT-6, Concussion in Sport Australia Position Statement, the Canadian Olympic Paralympic Concussion Guidelines, Centers for Disease Control, NCAA Diagnosis Management Handbook of Sports-Related Concussion, the NATA Position Statement from 2014, the Ontario Neurotrauma Foundation Guidelines for Diagnosing Pediatric Concussions from 2014, Proceedings from the International Ice Hockey Summit in 2019. Groups discouraging use, unfortunately, there's only one that we're aware of, and if you're in Canada, this is a problem, because that group is Canadian, and they've somehow convinced the rest of the sporting community that you shouldn't do a baseline test. I don't know why. Let's see what their arguments are, and let's put them to the test. But first, here's the CDC. Baseline testing generally takes place during the preseason, ideally prior to the first practice. It's important to note that some baseline and concussion assessment tools are only suggested for use among athletes ages 10 years or older. Okay. Results from baseline testing can be used if an athlete has a suspected concussion. Comparing post-injury test results to baseline test results can assist healthcare professionals in identifying the effects of the injury and making more informed return to school and play decisions. How often should they do it? Most components of a baseline test can be repeated annually to establish the valid test result for comparison. Proceedings from the International Ice Hockey Summit. So that parachute statement in Canada was in 2018. This was 2019, a year later. This group met. This guy right here is the doctor for Hockey Canada. These guys are involved in Hockey Canada. These guys are well-known concussion researchers. You can see John Letty's name here. So there's a lot of really good, prominent concussion researchers on this paper. They made 6 recommendations for hockey, international hockey. Okay? If you look at number 6, which is right here, mandate baseline testing to improve concussion diagnosis for all age groups. Mandated. That was their recommendation. Okay? So let's talk about the arguments against baseline testing. Why would Parachute come out and say that we actually shouldn't be doing baseline testing? Well, one of the arguments is the reliability. So the test-retest reliability and sensitivity is not good enough to support its use. The problem here is that the studies that show this are only testing one test at a time. And we know that in medical situations, doing one test is not a good idea, right? If you look at the overall sensitivity and specificity of something like the, anterior drawer test for ACLs, right? You're never just going to do one test. You're going to do a series of tests that lead you towards a diagnosis. So looking at any one test in isolation, you're going to say, well, they're not great. But in fact, there was a systematic review that was recently done that looked at the SCAT, the King-Devick, the impact and balance assessments and found that they're actually not bad. Even as standalone, they're actually not too bad. All right. But when we put them together, the results are even better. Let's take a look at this. Okay. These are various studies that used single test versus multimodal. King-Devick by itself identified 53% of concussions. The pitch side concussion assessment by itself identified 74% of concussions. CogSport by itself identified 57% of concussions. However, when they combined all three, they identified 100% of concussions. The impact test, symptom severity score, sensory organization test. When each test was used separately, almost half our sample was misclassified. However, when they were combined, they had to up to 100% were classified appropriately. Multimodal. This study here examined impact, King-Devick, SCAT, and reaction time. Ultimately, while none of these measures individually meet the reliability standards set for clinical utility, there is evidence that combining them in a multifaceted assessment model provides a high level of sensitivity by comparing baseline performance to post-concussion changes in cognitive functioning. This study had 4,800 people in it. Merendez. King-Devick alone found 79%. SAC found 52%. Combining King-Devick and SAC captured abnormalities in 89%. When we added in balance to those two, we got 100%. All right? So how often should we be doing this? Well, typically we do it annually. Now, this gets called into question. We actually need to be doing it more frequently in younger people. So this study was on 660 high school football players. They completed 2 baseline assessments 1 year apart. Participants were separated into 3 groups based on age. So they had 14-year-olds, 15-year-olds, and 17-year-olds. I don't know what happened to the 16-year-olds, but they weren't there. The results. There were differences in baseline performance between age groups, with younger athletes demonstrating improvements in performance consistent with ongoing cognitive development, and older athletes demonstrating more stability in their performance. So one of the knocks on doing baselines in younger athletes is like, well, they're still developing, right? So if you do it this year and they're, 11, by the time you do it next year and they're 12, they're going to be so much different. So if they get a concussion when they're 11 and a half, are we actually comparing apples to apples? Well, the argument would be no, but it depends on the tool you're using. So this is impact. These findings indicate younger athletes should ideally complete baselines prior to each athletic season, meaning more frequently than every year. Right? If they're going to play football and they're also going to play hockey or other sports at different seasons, they should be doing one for every season. The problem with impact, however, is that there's a learning or practice effect. Impact has the same words they've had since 2000. They have the same shapes they've had since 2000. Actually, it's 1999. Okay? So the test is the same. So what happens is people just remember the words from the test they did last year and the year before that and the year before that and the year before that. So once you've done that test a couple times, you're not actually testing what you should be testing anymore because the words are always the same, the shapes are always the same. So there's a practice effect. So that's why we use something called the Dana test. Now the Dana test is free on the Complete Concussions app. If you go to the App Store and download Concussion Tracker and you create an account, you will be able to do a neurocognitive test. This test, why we use it, it was built by a U.S. Department of Defense contractor for use on the battlefield. So it's available on a mobile phone, which makes it easy to do anywhere. You can do it on the sidelines. You can do it at home. You can do it, wherever, in the clinic. It is the most sensitive concussion test that there is on the market from a neurocognitive perspective. It also has built-in mental health screening, which is such an important factor for concussion recovery, but also even just understanding who has maybe some anxiety that should be dealt with, even if they don't have, even if nobody knows about it. So it has the GAD-7 for anxiety, the PHQ-8 for depression, and the ISI for sleep. And the big thing here is that there's no learning effect. This test is completely random every single time you do it. So you're not getting the same shapes, you're not getting the same letters, you're not getting the same words. It's completely random every single time you do it, so there's no learning effect. So it's actually testing what it needs to test. And the beauty of this is you can do it very frequently. And we actually encourage people to do it as much as possible. Because the more you do it, we've built in algorithms to create normative reference ranges for each person. So what it'll do is if you do this test today and you do it next week and you do it the week after that and you do it the week after that, there's going to be variation around your scores, based on the day, based on how fast you were moving that day, whatever. Now what'll happen is our algorithms will figure out what your range of normal is. And the more you do it, the tighter that range gets and the smarter the test is at picking up any type of deviation from that. So that gets rid of the practice effect and allows us to do it more frequently. So you have a very sensitive test. We also have built-in validation criteria, which prevents sandbagging. So sandbagging is the idea that someone's going to try and fail the test. So with, Impact, for example, which has been around forever, and I'm picking on it because they've done studies on this, but there's built-in criteria in Impact that basically will say, okay, this person is trying to sandbag. This is not a valid test. But what the research shows is that those criteria are not strict enough, and people are able to get around that quite easily. So people will purposely fail it, but just on the edge of being detected. And this can happen as many as 30% of cases. So it's not very good at picking up the sandbaggers. Whereas the things that we've put in here are very good at picking up it's a hard test to even get a valid result on because of that. So here's the individualized reference ranges. So this is neurocognitive. This is what happens on our clinical system. So people will do this test on their phone and the data feeds in, which is really nice for baseline testing. Because if you're going to do baseline testing on a group of people, it's easier just to say, download the app, do the test, and then the results come right into my system. So I can see everyone's results immediately and I don't have to get them into my clinic necessarily. I can do this, very quickly. So you can see this normative reference range starts to develop, and then you get an injury, boom, and you're outside of that reference range. As you recover, you come back into that reference range. Good. Same thing with balance, right? It develops individualized ranges for balance. We also have a balance app on our phone that you close your eyes and you do various stance positions, and it uses the gyroscopes and accelerometers and stuff inside the phone to pick up your postural sway. Now, we validated that with force plates. So this is going to give you the same accuracy level as if you were going to use a high-powered force plate in your clinic to look at how much sway is going on in someone's posture. And again, because it's on a phone and they can do this test over and over again, it'll create individualized normative reference ranges for each person. The more they do it, the better it'll get. Here's the Dana test, sensitivity of Dana, neurocognitive and fine motor deficits in asymptomatic adolescents. This is the ability to pick up issues beyond symptom resolution. So this one was looking at asymptomatic adolescents. If you look at this is kind of what they were talking about in other studies, right? So they said in a separate population with sports-related injury, Impact, ANAM, and Axon or Cogsport, these are other neurocognitive tests, revealed deficits within 24 hours of injury, but were deemed to be insensitive after that time. In contrast, the Dana test has been shown to be sensitive to persistent deficits in the subacute period after concussion in active duty military populations. However, it's never been evaluated after concussion in adolescents until this study. And what this study found, this is from the abstract, there were no differences in self-reported symptoms on the post-concussion symptom scale comparing concussed to non-concussed adolescents, meaning these are people that had a concussion, but they had recovered symptomatically. All right. And then they compared that to a control group that never had a concussion in the first place. On impact, they found no significant between group differences. However, performance deficits were apparent for the Dana assessment, reflecting lower throughput scores for simple reaction time and response inhibition parameters. So you can see here the area under the curve, or the ability to diagnose concussion in the non-concussed versus concussed, was 70% accurate with impact. However, with Dana, it was almost 80% accurate. And if you look at just the simple reaction time alone, 84% accuracy rate, just in that one test alone. And this is after the symptoms have gone away. This tool was still picking up deficits in these people. So the sensitivity is not there. The retest reliability is not there. What tools are you using? That's the whole thing. Are you using just one? Then yeah, I would agree. Are you using a battery? Yeah. Are you using Dana versus impact? Then I would agree, no, Dana's better, right? So it's all of those things. It depends on what tools you're doing. Argument number 2, you don't need a baseline to make a diagnosis. This is true most of the time. That's 100% true most of the time, right? The highest diagnostic accuracy in much of these tests is the symptom score. Okay? But the new ACRM diagnostic criteria now require having 2 symptoms as well as having objective evidence. Okay? If you don't have any objective evidence, the best you can do with symptoms alone is to call it a suspected concussion. You can't confirm it or diagnose it as a concussion without having that. Okay? Now, what happens when the symptoms are minimal or kind of light? What happens if the athlete doesn't report any symptoms? Right? You're like, something's not right with this guy, but he's saying, I'm fine. I don't have any symptoms. Do you have a headache? No, I'm fine. What can you do then? Or what do you do when the symptoms have gone away? That's what we're talking about, right? Return to sport. Here's a study from Broglio. The lowest chance for misclassifying concussed athletes on the sideline was found when the evaluation of SCAT symptom inventory, SAC, and BES on a firm surface were compared with the same season baseline evaluation. So it's still super helpful at the point of diagnosis. Now, can you make a diagnosis without it? Well, yeah, you can call it a suspected concussion. Or if you see clinically observable signs, you could call it a concussion. But without having any objective evidence, you can't call it a concussion. Here's highlighting the idea that it's for return to play. Okay? Despite being symptom-free, this is a systematic review. Despite being symptom-free, athletes in all 15 studies showed lower performance compared to controls on tests of visual and verbal memory and on processing speed after concussion. All studies report specific neurocognitive deficits after MTBI, although the athletes were declared clinically symptom-free. Therefore, systematic consideration of neurocognitive parameters and return to play decision-making is recommended. Here's another one. The use of baseline tests in adolescence is controversial, and recommendations about their use are evolving. The fact that computerized neurocognitive testing results consistently contributed to a negative return to play decision in 2 out of 3 cases suggests that variables assessed by this measure may be more sensitive to residual subclinical impairment than the variables used to determine clinical recovery. Return to play, not diagnosis. Argument number 3, well, you don't need a baseline because we have normative data. No, we don't. And I'm going to show you. So there's several problems with that. We don't have norms for all tests. Some of the computer tests do have norms, like impact has normative reference ranges. However, when we do studies on those normative reference ranges, we find that they're not actually accurate. People are all over the place with respect to their norms. So studies using normative data versus baseline results have shown dangerously high misclassification rates. This study by Schatz looked at impact, and when they compared it to baseline versus just using normative reference ranges, when using the normative reference ranges, 50% of the sample was misclassified, either as concussed when they weren't or not concussed when they were. Katz, 2018, the norms posted by impact are not the norms found in a large study of 15,000 NCAA athletes. So the published norms might not even be accurate. DaCosta, 2020, balance versus baseline is better than balance versus normative data. Anderson and Biley, the King-Devick baseline versus norms, the most reliable use of the test as a screen for impairment involves the use of a baseline test. There aren't norms for most tests, and those that are there are potentially inaccurate, and there's also all these other problems. People are not the norm. Normative data is influenced by all of these factors. Whether you're male or female, any mental health, anxiety, depression, PTSD will influence your scores at baseline. Learning disabilities and learning exceptionalities, behavioral disorders, ADD, ADHD, whether you play a contact or non-contact sport will influence what your scores are. Race, socioeconomic status, history of headaches, physical disabilities, right? People in wheelchairs. diabetes. Even your blood sugar level will impact your cognitive scores. So in order to have proper norms, we would have to have normative distribution for every single test, for every single age, for both genders, for sports, every single sport that people play, every single race that's out there, so that we can try to develop these normative data tables to be able to accurately interpret somebody's post-injury test results if they didn't have a baseline. Now, how do we get the normative data? Well, we do baselines. It's the best thing we have right now, and it also allows us to collect a lot of data, which can eventually give us the normative data pools that we need in order to have normative data. Here's another one. Like this one's looking at sociodemographic and health variables with baseline concussion testing in youth. So this is 2,700 athletes included. They found that higher symptom scores are related to lower socioeconomic status. A lower SAC score was significantly associated with male sex, being younger, Black or African American race, Hispanic, previous diagnosis of learning disability or ADHD, or lower socioeconomic status. Higher mean King-Devic time, meaning a slower King-Devic, was related to younger age, previous diagnosis of a learning disability or ADHD, and lower socioeconomic status. So here's the conclusion. Normative data may not be appropriate to use when interpreting post-concussion assessment in all athletes. These findings emphasize the importance of baseline testing to establish individualized concussion assessment standards for each athlete. And even on the SCAT, one of the recommendations they made in the paper about the SCAT was to create stratified normative databases that include age, education, cultural background, and para-athletes. So if we have all these norms, why would they make that recommendation? Because we don't. We don't actually have them. That's a lie. All right, next argument. Tests have not been validated for younger patients. Well, what tests? Right? Some tests, yes, many of the computer tests have not been validated for younger patients. The Dana test, for example, we basically do in people only over the age of 12 because we don't have anything younger. That's fine. There's other things we can do. Other tests are validated in younger kids. For example, the King-Devic test is validated. So we can use those tools. All right. So there's a nice summary here from this paper on baseline testing, okay? Concussion baseline testing is necessary to ensure that athletes return to sports safely after a concussion to decrease the risk of returning to sport prematurely. Although normative values can be used to determine return to play in the absence of a baseline test, they are not always an accurate standard for comparison. Baseline testing provides clinicians with an individualized comparison for each athlete upon return to play from concussion and decreases the likelihood of improper return to play decisions. Because of the complexity of concussion injuries, a multifaceted and individualized approach to baseline testing is recommended. This multifaceted approach may be assessed with a single test, for example, sports concussion assessment tool, or across multiple tests. However, it is important for clinicians to recognize the difference between sideline diagnostic assessments and those that can identify recovery. Most adult athletes return to their SCAT baseline scores within 5 to 7 days. Actually, it's 48 to 72 hours. However, the average time to complete recovery after sports-related concussion is 10 to 14 days. Actually, it's 21 to 28, as we've seen, 22 to 30, right? Therefore, SCAT-5 is only intended as a multifaceted sideline assessment for sports-related concussion. Clinicians must include additional measures that can determine full recovery across multiple domains in their baseline and post-injury testing to improve return-to-play decisions. Although baseline testing is recommended, there are factors associated with each athlete, environment, test, and clinician that may influence baseline scores positively or negatively. For example, sandbagging, distractions during testing, and also practice effects. So we need to account for that in the tests that we do. So we need the right tests for the right purpose. Are we looking for sideline or return to sport? And we need the right athlete. What tests are better for which age? That demonstrate minimal practice or learning effects and have built-in effort measures to detect sandbagging. That's what we need. And we have it. We can't just have a blanket statement that says baseline testing is bad. What tests are you talking about? What age are you talking about? What purpose are you talking about? So here's the additional benefits, right? We have educational opportunities. Research showing people coming in and doing a baseline were more likely to report having a concussion if they get in the future because they have that education to understand what the symptoms are. And earlier presentation to clinics. One of the number one predictors of recovery time after concussion is how early you're in to see a trained concussion provider, somebody who knows what they're doing. We know this. And we have better recovery outcomes in those people. And we did a study looking at CCMI data in 2022, and we found that athletes with a baseline test was one of the number one predictors of who would actually come into the clinic sooner. So getting a baseline test, because you have their data, means that they're going to come to you immediately, which means that you're going to be able to get them started on the right things early, rather than having to go to some GP that doesn't understand concussion at all, tells them to rest and do nothing for 6 weeks, and now they have a disability. Whereas if you have their data and you know what to do, they'll come to you and you can get them going on the right thing, improve that recovery time. So should we test or should we not test? Well, recovery is the most important aspect of proper concussion management. Symptom resolution occurs far before brain recovery, so that's a risk if we don't address that properly. Without understanding where someone was pre-injury, all return to play decisions become a guess. I don't care who you are guessing if you don't have any objective data around this. We don't have any good normative data. Misclassification rates with normative data are super high. Baseline tests are currently the best option that we have. A single test is not a good baseline. We need to have, a single test will have moderate sensitivity, possible issues with reliability on a single item. Different tests have different purposes, right sideline, return to play. Multiple tests improve these concerns substantially. We should be doing this annually for high school and younger. College and pro should be less frequent. And even high school and younger, if you have tests that don't have a learning effect, you should be doing it even more frequently than that. So here's some common tools, right? We need tests to be comprehensive, stable, hard to sandbag, sensitive, valid, and have a low learning effect. SCAT-6 is comprehensive. It covers multiple domains. However, it is not stable over time. The test-retest reliability is quite poor. It's very easy to sandbag. If I give you a list of 10 words and you tell me you can only remember 3 of them, I have no way of validating whether or not that's accurate. I just have to take your word for it. It's not sensitive, right? The symptoms go away after about 7 days, but this thing normalizes before the symptoms even go away. 48 hours to 72 hours. It is valid. It has been validated. It is a measure of cognitive function. It is a measure of balance. Is it a good one? Probably not. Low learning effect? No. Anyone can look up the SCAT. You can Google the SCAT, get all the words and everything you want. Head check is basically the SCAT on an app. So it's all the same kind of drawbacks as that. Now you're just paying money for it when you can do it on paper. Now you get to do it digitally. Impact, right? Not comprehensive. It only tests neurocognitive function. It is not stable over time. The test-retest reliability is not that great. Hard to sandbag, we've already said no, it's not, because the word lists have been the same since 1999. Sensitive, not really. Typically, once the symptoms go away, typically you'll see a lot of the performance things come back to normal. Is it valid? Yep, it does measure neurocognitive function. Low learning effect? No, it's the same test over and over and over again. Same words, same shapes, right? Sway is a newer one, right? It's comprehensive because it does neurocognitive and it does balance. Is it stable? Well, the balance test has been shown to be stable. However, the results on the cognitive tests are kind of mixed. Hard to sandbag? We don't know. It's never been studied. Is it sensitive? We don't know. Never been studied. Is it valid? Well, the balance test is, but the neurocognitive piece has never been studied. Low learning effect? Never been studied. Whereas what we include in all of this, and this is kind of what we always strive for, is to make sure we're covering all of those boxes. All right? So here's return to sport. Now this is the Amsterdam group, and this is kind of how things go. So step 1, same as it always is, symptom limited activity, right? You can do daily activities that don't exacerbate symptoms, gradually increase reintroduction of work and school. Pretty typical. Aerobic exercise, and they broke this now into 2A and 2B. Now remember, each of these stages should be separated by 24 hours. So now you've done your symptom limited activity, you're moving on to exercise. 2A is light exercise, up to approximately 55% of your max heart rate. If you're okay with that, then you can go on to 2B, which is moderate, up to 70% of your max heart rate. This could be stationary cycling or walking at a slow to medium pace. May start light resistance training that does not result in more than mild and brief exacerbation of symptoms. The goal here is to increase your heart rate. Now, we have a different stage that we throw in here because it also helps with speeding up recovery time if you do this at this stage, but I'll show you that in a second. If you're okay with the light exercise, then you can move on to sport-specific exercise. Note, if sport-specific training involves any risk of inadvertent head impact, medical clearance should be obtained prior to step 3. So basically you're supposed to do non-contact sport-specific training drills here. Sport-specific training away from the team environment, like running, change of direction, individual training drills away from the team environment, no activities with any risk for head impact. Once you get to this stage, this is kind of your medical clearance stage. Steps 4 to 6 should begin after the resolution of any symptoms, abnormalities in cognitive function, right? How are we going to know that those have resolved if we're not testing them? And any other clinical findings related to the current concussion, including with and after physical exertion. Here's where the physical exertion piece comes in. Okay? So this is our medical clearance stage. So they have to be asymptomatic at rest, asymptomatic with physical exertion, and have no issues with cognitive or physical function, both at rest and with physical exertion. So this is our medical clearance evaluation. If they're okay with that, then they can go into non-contact training drills, which is basically higher intensity training drills. Okay, still should be non-contact. Then if they're okay with that, they can go to full contact practice. Then they can move on to full game play. Now here's how we look at this. So same thing. We have return to learn and work on this side, return to sport on this side. Symptom limited physical activity occurs, step 1, same thing. Now for our light physical activity, we actually bring them in and do a Buffalo concussion treadmill test. So if it's been any more than 3 to 4 days, even if they're still symptomatic, we'll put them on the treadmill. And the reason is because subsymptom threshold exercise is therapeutic for concussion recovery. So if we tell them, if we're using this thing, and we say, okay, just go exercise at 55% of your heart rate. And they're like, oh, that really flared me up. Okay. Now the process here is we go back to stage 1 and then try that again in another day or 2. Okay, they tried again. Oh, it still flared me up. Okay, go back to here and just rest again. Oh, it flared me up again. Okay, go back here and rest. Whereas with our scenario, they come in and they do it. And we say, okay, what heart rate did you get flared up at? Okay, I want you to exercise every day at a heart rate below that level. Now they're actually doing something to improve their outcome. So I way rather put a Buffalo treadmill test here than try to give them this self-directed 55%, 70% kind of garbage. I want them getting on the treadmill for us to figure out a threshold rate. If they pass, they go to stage 3. If they fail, they're now in the subsymptom threshold exercise program, which is a rehab program. And we know that just by doing exercise alone within the first week after concussion reduces your chance of having persistent symptoms by 50%. So we want them doing this. After sports-specific activity, and they're basically back to full days of school and work and have no symptoms at all, now we can move on to our medical clearance evaluation, where we do a physical exertion test, Blackhawks test, as well as a comprehensive baseline retest, if we have it. If they pass both of these elements, then they can move on to non-contact training drills, then full contact practice, then full contact, then return, full contact return to game time. So here's our medical clearance evaluation with complete concussions. We have a dynamic physical exertion test, which is our Chicago Blackhawks test. Then we retest their baseline results. If we don't have a baseline, we'll run them through the Dana, because there are some things you can do without a baseline on Dana, as well as a VOMS test. Now this isn't perfect, but it's something. Why dynamic physical exertion? We already did a treadmill test. Why do we have to do another physical exertion test at this stage? Well, the test that we use is called the Gapsky-Goodman test, or we got it from the Chicago Blackhawks. I did a study on this. We looked at 759 athletes who had done all of their return to sport. Because back in the day, the medical clearance used to happen after their second non-contact practice. Now they've moved it into the middle between the two practices. So we would have people going through their entire return to sport process. They would be asymptomatic at rest, asymptomatic with physical activity. They've done a bunch of practices and they have no issue. They come back in, we put them through the Blackhawks test. 15% of them have symptom provocation with this test. And I'm going to show you what that test is in a second. Okay, symptom recurrence with the Blackhawks test. Of the 85% of people who passed, roughly 40% of them then went on to fail one or more elements of their baseline test. So these are people that would have been cleared in any other scenario. Yet about half of them were not ready to return. And if we didn't do this process, we would have been returning all these people early. Same thing with this study. This is the Journal of Athletic Training. Popovich compared a standard aerobic exercise protocol against a dynamic exercise protocol on adolescents with a concussion. The dynamic picked up way more symptom provocation, even in those who had passed the standard aerobic testing. This is why we can't just do the Buffalo. We have to do a more dynamic test after. Symptom onset doesn't happen with, people might say, right? Well, this is just because the test is hard and maybe you're just making them symptomatic because you're doing all this stuff and it has nothing to do with concussion. Well, these same tests across all these studies done on healthy people does not provoke concussion-like symptoms. So that argument is out. Now, after they do this physical exertion testing, we want to challenge them by doing their baseline while in an exerted state because it increases the sensitivity of those measures. So while we're doing a baseline, we want to stack the deck in our favor, we want to stack the deck in the athlete's favor during a baseline. We want them to perform tip-top shape. We want them coming in well-rested. We want them coming in hydrated. We want them coming in not after a practice, right? We want them coming in good to go. But when we're retesting after the concussion, we want them in an exerted state. We want to stack the deck in our favor. We're trying to throw everything at them so that they don't pass. That's my goal. If you come in for your medical clearance, I'm going to try and not pass you. Because then if you pass, I feel confident that you're actually ready to go. I'm throwing everything at you. See what you got. Okay? So this particular study, 27% of asymptomatic athletes who had completed return to play and passed the impact test at rest subsequently failed it following physical exertion. Zering, 2015, similar results to this one. 28% of patients who had passed impact failed it after a physical exertion test. Okay? My study, I just showed you 40% of people failed. Sicard, 2018, the added value of post-exertion assessment. 45% of asymptomatic athletes who were cleared to return to play subsequently failed neurocognitive testing. Of these, 10% failed at both rest and exertion, 13% failed on rest only, 22% failed on post-exercise. Their conclusion, this current study suggests that 1 out of every 2 athletes who successfully completed the return-to-play protocol exhibited diminished cognitive functions compared to controls. The use of a sensitive cognitive test combined with physical exertion can prevent premature return to play in identifying athletes who have otherwise received medical clearance. Lichtenstein and Mertz, 2019. 36% of the 240 asymptomatic athletes at rest and with exertion failed one or more elements of their post-exertion impact test. Return-to-play protocols should include post-exertion neuropsychological testing, as relying on athletes' symptom report will miss a significant portion of athletes who are continuing to recover from sports-related concussion, putting them at risk for additional repeat injury. Post-exertion neurocognitive test failure among student athletes. Conclusion, clinicians' return-to-play evaluation protocols should include post-exertional computerized neurocognitive testing. Now, here's the Blackhawks test. I did show this in the presentation, but I'm not going to give it away to the internet. If you want to learn more, you can check it out on CompleteConcussions.com. We have some explanation there. Now, we also have to consider the risk for MSK injuries. So if we're doing a return to sport on somebody, we know that there's an increased risk of MSK injury after concussion. Quite a substantial one. These studies show unclear or no increased risk. But you see the evidence for increased risk, 4.7 times greater risk, 2.3 times greater risk, 2.25 times greater risk. So we know there's an increased risk, it seems, for MSK injury after a concussion. Now, we may be able to prevent this. This study by Howell found that an 8-week neuromuscular retraining program prior to returning to sport after concussion resulted in 2.6 times less injury risk when compared to the usual kind of care group and just letting people go. Now, this study was underpowered, but it's something to consider. Could we do kind of like a FIFA 11 plus type return to sport protocol for people with concussion to mitigate their risk of lower limb non-contact or MSK injuries? So here's the take home. Right? Symptoms do not equal recovery. Baseline testing is extremely important, but it is controversial. You need the right test for the right purpose, for the right patient, etc. Physical exertion testing is also important. You need general physical exertion testing at the start of your return to sport to put them on a subsymptom threshold exercise program if they pass. But if they fail, you put them on that. If they pass, then you can keep going with the return to sport. At the end, you need a dynamic physical exertion test, because that straightforward treadmill test doesn't work. You need to have heart rate up, heart rate down, heart rate up, heart rate down. You need to get them spinning and jumping and doing all sorts of different maneuvers to mimic that kind of dynamic physical exertion. Then you should follow that up with a baseline retest in an exerted state to increase the sensitivity of that measure. Other considerations for return to sport, psychological readiness. We didn't really cover that, but that's a big thing that's becoming more of an issue now. You need to know if people are ready to return. And then MSK injury risk. Consider neuromuscular retraining as part of the return to play process. And that's it. I hope you enjoyed this session on return to sport management. This was given at a conference in Toronto. And if you like it, please comment, share, do all that fun stuff. Thanks.